The last section in this podcast will be on infarct. Do the ischemia, injury, and infarct patterns represent a time frame? And why do the students need to bother knowing the leads and what area of the heart they represent is listed in the guidelines?
Very good questions, and absolutely right about the timeline. If a plaque, for instance, suddenly occluded a coronary artery, the myocardial cells would first show the deep symmetrical T-wave inversion of ischemia from the relative decrease in blood flow. Then if the occlusion continues, the cells would next experience actual injury and begin to show the injury pattern of ST elevation. And finally, the cells would die and you would see the Q waves of infarct. This is why it's so important to do fibrinolytic therapy or angioplasty as soon as possible in the setting of acute coronary insufficiency. As far as knowing the leads and what area of the heart they represent, this is very important for prognosis. Any acute damage to the left ventricle can trigger serious arrhythmias and certainly can cause sudden death. However, patients who get through the first 24 or 48 hours, the prognosis often depends on the location of the infarct. As an example, the anterior wall is much more serious. It usually will decrease your ejection fraction and cardiac reserve. And also it supplies important areas of the conduction pathway and can lead to more serious heart blocks, such as a Mobitz 2 or 3rd degree. Inferior wall myocardial infarcts usually affect the ejection fraction much less and cause less serious blocks, such as 1st degree or Winkie-Bach. These patients are often asymptomatic, and when you see these patients in the clinic, oftentimes the anterior wall patient will have several steps of easy dyspnea, and sometimes it might have a pacemaker. The inferior wall MI patient may be completely asymptomatic, and you would never know it if they hadn't mentioned it to you or you had seen an EKG. So at this point, it might be useful to take a look at some of the examples again on the slides. And the first one we'll look at is labeled ischemia. And here, I think you can see, especially in leads V2, V3, V4, and V5, that the T waves are deeply and symmetrically inverted. They're also noticed in several leads in the anterior wall. So you wouldn't call these a strain pattern. First of all, there's no hypertrophy. Second, these are symmetrically inverted, and they're in several areas of the heart, and this is very early on in the course of an ischemic event. You would like to get this patient in the ER quickly before you see any further time get past. The second example is an injury pattern, and that's the ST elevation, and in this one we can see it in V3, V4, and V5, a little bit in V6. And you'll notice that the QRS pattern never really comes back down. It's the ST segment is elevated off of the baseline, and that point where it is elevated you'll sometimes hear referred to as the J point, but this is an acute injury pattern. This patient is now further into the course of their myocardial infarct, and although this is still a patient you could intervene on, you would like to catch them a little bit earlier if you can. And finally, the last example labeled infarct shows Q waves, and this is the patient where the myocardium has actually died. And Q waves can be seen in V2, V3, V4, and we often get the question of what is a Q wave? And definition of a Q wave is when you follow the QRS complex, the very first deflection, if it's down, it's a Q wave. Even if there's a small spike that suggests an R wave, then that would help you differentiate. But clearly there's no spike up initially, they're down. This is often called by residents Qing out, or the patient is now having Q waves present, which may mean an old infarct. And of course, you can have these processes occurring together. For instance, you might have some ST elevation, and in addition already start to get some Q waves of the dead myocardial area.
Thank you very much, Dean.
You're welcome.
Just to review, please review back to the website and to print out the guidelines. Thank you all for joining us for this Primary Care podcast. There is a second podcast on ECG rhythms and the clinical issues surrounding them. Hope to see you there.